All right, I do want to keep us sort of on time this evening, so I am going to go ahead and start. My name is Jen Chambers. I am the Assistant Vice President of Lifelong Learning at Alumni Engagement and Development. I am delighted that you are joining us this evening. We have a great program. I think one of the most amazing things about these Zoom opportunities that we have with this particular program is the opportunity to bring together people not only from our alumni base from all over the place, but also from all over Duke University. Tonight we have professors from the School of Nursing, from Fuqua, from the Sanford School, and from the School of Medicine. And we are joined this evening by Dean Vincent Ramos from the School of Nursing, who is the new dean. And I will introduce him here in a moment. So it is a panel discussion this evening about the disparities in healthcare. This is the third of 4 sessions within our Wicked Problems theme for this fall. And all of the sessions that we've done this fall will be on our YouTube page. So if you come in a little bit late or need to leave a little bit early, or you missed any of the previous sessions for this semester, they are all available on the YouTube page, and we will include those in the follow-up email so that you can link easily into the content that we've already shared this semester. So welcome. It's now my pleasure to introduce Dean Vincent Ramos. Vincent came to Duke on July 1st from NYU, where he was professor and associate vice provost for mentoring and outreach programs, and held academic appointments in the NYU Schools of Nursing, Social Work, and Public Health. He is the 12th dean of Doosan, the 2nd alumni dean, the 1st male nursing dean, and the 1st Latino dean at Duke. Vincent is a nurse practitioner, dually licensed in primary care and psychiatric mental health nursing. He is credentialed as an HIV specialist by the American Academy of HIV Medicine. Vincent received his PhD from the SUNY Albany School of Social Welfare, his Master of Social Work degree from the NYU Silver School of Social Work, as well as a master's degree in the management and a Master of Public Health degree, both from NYU. At Duke, he earned his Master of Science in Nursing degree from the School of Nursing in Nurse Practitioner Primary Care with an HIV specialization. He has maintained an active research program garnering extensive funding from the NIH, CDC, and other federal agencies and private foundations. He has also been a leader in reducing health disparities among youth in the Latino and other ethnic minority communities. To that end, he brings to Doosan the Center for Latino Adolescent and Family Health. Vincent's advocacy work extends outside the Duke University field, and he currently serves as a member of the Presidential Advisory Council on HIV/AIDS, the HHS panel on antiretroviral guidelines for adults and adolescents, the CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment. He also serves on the Latino Commission on AIDS Board of Directors as vice chair, the Power to Decide Board of Directors, and the Ending the HIV Epidemic Working Group of the HIV Medicine Association as co-chair. So please join me welcoming Dean Ramos to this evening's session, and I will turn it over to you.
So thank you so much, Jen. That was certainly a mouthful there. There was a lot of information. And so I just want to say thank you. I'm Vincent Ramos. As Jen said, I'm the new dean here at the School of Nursing. Very happy to be sharing the opportunity this evening to be with all of you. And I get to sort of do the fun part, which is to introduce the panel and to actually moderate this evening. Before I start, I just want to sort of share my screen and see if my slides will come up. And so hopefully everyone can see that. We're going to be talking about disparities this evening and social determinants of health. But I think what's really exciting about what we're going to be up to is that we're actually moving beyond what traditionally has been the focus. You know, too often there's characterization as opposed to really discussion of, you know, sort of solutions and how we can have real world impact. I'm not sure, guys, why my slides advanced, but forgive me. But I think that what we're hoping to do tonight is to not simply discuss things that we know and that have been known for quite some time. We're trying to think about innovative ways to discuss novel approaches and solutions. I'm really happy to have sort of an esteemed group of panel members, and I'm excited to hear and learn more about their work and better understand sort of what's happening across Duke. So my slides are kind of moving on their own, so I'm not sure what's happening, but I wanted to spend some time talking about sort of changes in the healthcare context. And for me, what's depicted on the slide that you see right now is sort of this notion there being really large-scale transformative events that have impacted on not only our community and country, but our globe. And so in the US, you can see here that some of those things have been, for example, the COVID-19 global pandemic that has had sort of profound impacts on all of us across the planet. But also there's been lots of attention to structural racism and sort of growing recognition of widening inequality. There's been concerns about mental health and behavioral health, certainly in North Carolina, and for that matter, across the US, issues regarding sort of substance use, in particular the opioid epidemic, gun violence, the border, which is something that I know that I and others on the panel think a lot about in terms of migration and population movement, and then demographic shifts and climate change. And these are all things that are part of our discussion this evening, but I want to highlight just a couple of points here. One, that these things have been very, very large and transformative. Many of them are contemporary, but also many of them are things that have been chronic. And because of some of the contemporary events, such as COVID-19, they provided insights into things that have been longstanding and historically part of the fabric of our country and beyond. So why does this matter? What is it that really we should be thinking about? And so one, I think it's commonly understood that social determinants of health, socioeconomic, environmental, and lifestyle factors, that they account for overwhelmingly the largest proportion or percentage of the modifiable non-genetic contributors to health outcomes. And when I think about the healthcare setting, which is the focus of tonight's discussion, I'm really in my mind thinking about it beyond traditional notions, but thinking about the brick and mortar structures, the sort of hospitals and clinics that I would consider the centralized healthcare setting, but also decentralized settings, communities, and places outside of our traditional notions of the healthcare setting. Both of those represent opportunities for us, and both of those represent ways that we can advance health and overall well-being. There are three basic relationships that I'm hoping we can sort of talk about this evening. One is, what are some of the direct impacts of these large-scale events that have caused health disparities? And so sort of a common example that is very present with us now is, for example, COVID-19. And we've seen that there have been mortality differentials between individuals that have been vaccinated or unvaccinated, but we've seen that that mortality has clustered in certain communities. Also, this idea that some contemporary events, as I mentioned previously, like COVID-19, that they shape things that have been historical. So what that image is trying to get at is COVID-19 sort of shining a light on other kinds of structural and contextual inequities that have preceded COVID, but actually COVID has made that more apparent for us. And then also what increasingly has been on my mind and part of the work that I'm currently doing, and that I think we'll hear about this evening, is these synergistic effects, and how is it that some of the contemporary sort of large scale events are interacting with things that have been pre-existing. And so with that, I'm actually going to stop sharing my slides, and I'm going to actually ask the panel to introduce themselves. I'm really delighted to ask each panel member to share a little bit about themselves and the extraordinary work they're doing here at Duke. And so I'm going to start by asking Catherine to introduce herself.
Hi, my name is Catherine Witten, pronouns they, them. I'm was a public health practitioner long ago and decided that getting a PhD would be really helpful in advancing what communities believe to be and know to be their health problems. So I got my PhD in population health sciences, and my appointments are in public policy and global health here at Duke. And what I'm really looking at through different foci of HIV, substance abuse, mental health, what happens with kids, is looking at life course events and the influence of the environment, policy, all of that on how we behave, how we interact, and how, with the goal being, how do we create a different kind of environment that allows people to have the well-being that they want to enjoy.
Thank you. Peter?
Hi, I'm Peter Ubel. I am a general internist that somehow found myself on the faculty of a business school, which might even confuse the business school more than it does me at this point. I study how people make decisions about health and healthcare. I've mixed a clinical and research career for several decades now. But a lot of what I've done also has been to mentor junior faculty in medical schools primarily. And as part of that, I've been very interested in the pipeline of how we get a diverse community of people to thrive within academic environments.
Nadine?
Yes, thank you. So as you said, my name is Nadine Barrett. I'm actually a medical sociologist by training. I'm faculty in the Department of Family Medicine and Community Health, and I'm really a health disparities researcher and a health equity strategist. Are the two ways in which I describe myself, really thinking about how do we create those strategies and those solution-oriented strategies, just as Dean Ramos just kind of highlighted, toward really creating those types of change that we want. And so that for me really includes integrating and fully engaging our community and our patients as true advocates, but as experts also who can really inform and drive the work that we need to do to be able to create the change that we want. And so that includes improving access to quality care. And what does that look like from a community perspective and a patient perspective? It means also when we think about increasing diversity in clinical research and trials, what does that look like? And what does that process, what should that process be? And really seeking that kind of guidance. And I think that that really speaks to that broader perspective that oftentimes in academia, we don't look to the community or to our patients for experts. We oftentimes think we have the answers. And I actually have learned through my own research that the best work I've done has always been where I've engaged fully as direct partners, community and our patients. And so that's a key part of what I do, both in the health system and in research.
Thank you, Nadine. And Rosa?
Good evening or good afternoon, depending on where you're calling in. My name is Rosa Gonzalez-Guarda, and I'm an associate professor at the School of Nursing. I started as a clinically trained public health nurse and went into research once I started to observe that there was a lack of evidence base to base my practice. And my work started looking at, like Dean Ramos mentioned, some synergistic conditions that clustered in the Latino Latinx community. And in doing that work, which is, I'll talk a little bit more about later, syndemics, I started observing that there were some common social factors that were really linking these conditions together. So now my work primarily focuses on trying to understand those social and structural factors that ultimately influence Latino health and health disparities.
So thank you. So before we start, I'd like to set the stage a bit with just some framing comments, and then I'm going to pose a question, and I'm going to ask that each of you maybe try to respond to that question. So first, one thing that's so fantastic about our panel today is that when I look at each person's area of research, it really is quite impressive that all of us are addressing social determinants of health. And what excites me about our being here together at Duke is that we have very diverse areas of research, but we have a common goal of really reducing health disparities. I think there is a significant potential for having impact. And I think part of what we're trying to do this evening is talk about real world impact and how we can have sort of solutions to some of the challenges that we're currently facing. I'd like to ask the first question. And I think to set the stage, the question is framed by the following statement. When working to dissolve health disparities, I would advocate that we must start by considering the impact of the social determinants of health, factors that largely fall outside of traditional notions of the health system framework, and how they affect an individual's and a community's ability to reach their full potential health and well-being. Therefore, I'd like to begin our conversation by asking each of you, our expert panel, to really share a solution that is part of the work that you're currently conducting, and to share some kind of notion of impact, a solution, and how that relates to the work that each of you is currently involved in.
So I'll jump in and say, you know, I've got a policy bias. And so kind of working from policy to environment to kind of neighborhoods, if people, when it not thought about when we're thinking about healthcare oftentimes, but if people can't get loans, whether they're bank loans for a house in a particular area or they're for a farm that you're trying to get hold of, you are then, and people are forced to live in certain places and certain conditions, it affects the environment that we're in, it affects our ability to gain wealth over time, and all of that influences kind of, when I look at the life course perspective of a kid who's born into a place that is impoverished and that it's hard to get good food and there's chronic stress within the house because of not being able to have stability in income and that kind of wealth build, all of that influences that kid's then trust and belief in the environment that they're in, which then comes to, okay, I've got a disease and what do I think of the healthcare system? So coming back to what we're talking about, so the entire environment from our policy, a policy that may not seem related at all to healthcare from someone looking from the outside, which is about, who's getting loans, who's making, all of a sudden is influencing this kid who is trying to come up, who has incredible potential, but can't meet it because of the environment that they're growing up in, the family that they're growing up in. We know for anyone that when you are at the poverty level, have an income level that is just around the poverty level, violence increases within the home. There's just so much stress. And so within the work that I do personally, we try to address all of those components. And I won't say much more than that at this point, but when we're looking at health disparities, we're looking at belief systems, behaviors, what's going on in the environment, and working kind of both at the what are the policies that we need, that I think right now we're doing an amazing job at making things more transparent. How do we change those policies? And then how do we work with communities to bring them up and to actively say, these are the things that have happened within your lives, within our lives, that have led to where you are. This is not about you being you and you being not able to make it. So when I'm looking at people around substance abuse, mental health, HIV, those are the kinds of things that I'm looking at.
So Catherine, I really loved that you started the discussion around policy and sort of framing it as being something that is not solely at the individual level. Maybe Peter, I'm going to pivot to maybe thinking a little bit about the individual level and talking about behavioral factors or decision-making, economic factors. What do you think, Peter?
Well, actually, you're making me regret my career choice, because you asked, outside of the health system, talk about what's going on there. And my work is almost all within the healthcare system. And I mentor a lot of undergrads who are pre-meds at Duke. They find me. And after I try to talk them out of going, do they really want to do this? But when they often say, I want to help people be healthier, I'm like, well, then you should go into education policy, or you should go into urban, policy, urban design, things like that. Most things that determine health aren't within healthcare. So I think but the work that I do, I think it's certainly, I've looked a lot at food behavior as another thing that I've done, where again, we find that there are so many influences from advertisers to neighborhoods where it's hard to find healthy food that probably have a bigger determinant on people's health than the healthcare system does.
Thank you. So Nadine, building on what Peter just shared, I wonder if you have thoughts on discrimination, implicit bias, and also access to care.
Yes, that's great. And again, just a great group of us that's being brought together here. When we talk about the social determinants of health in general, they are so big. And when we really think about how our systems and our society has been structured, historically, it was designed in such a way as to ensure that some benefit and others don't. And that goes over 400 plus years ago. We can start from slavery, move all the way up, and we can certainly speak about the Black experience, which I'm very much, I do a lot of work in that space, but that also speaks to the marginalized population, section gender minorities, people who live in rural areas, the Latinx population. And so when we think about the system and the way that it was developed really for all of these different groups to not necessarily succeed or to thrive, right? That's the nature of systemic and structural racism in its essence. And so when we talk about implicit biases and the values and the beliefs that goes with that, it actually really feeds into this whole, it kind of undergirds, if you will, the practices and policies that creates the inequities. Then our implicit biases kind of reinforces that, our perspectives that we have about different groups, the stereotypes that we have, and it's all based on what groups are valued and who's not, right? And therefore the policies impact all groups. And so when we talk about implicit bias and discrimination, we know discrimination exists. We've been seeing policies come through, from since forever, but most certainly in the 60s is the time that I think people were really very much so heightened awareness of the need for change during civil rights movements, both with Cesar Chavez, the farm workers, as well as with the Latinx, the Black population with Martin Luther King and Farrakhan, et cetera. So we can clearly see that exists across the board. And without question, as we look at discrimination, implicit biases now, there has not been really much shift or change in those perspectives that people have, the stereotypes that people may have about particular groups. We also see that implicit biases and this discrimination, if it plays out in our criminal justice system, in our education system, in the policies that our peers just talked about, there's no reason why we would think for one moment it does not also play out in our healthcare system as well. And so when we talk about the provider and patient interacting in this really important moment when we're thinking about what does it mean to actually get access to care, quality care. I'm actually from England, so I actually, back in the day, would focus more on quality than access, recognizing that people actually had access to care. And there were challenges there without question, but then we would miss the mark on not looking at the quality and the differences that happens in equality in quality care. So when we look at all of these outcomes and these different structural factors that I've just mentioned, it's not surprising then that people of color, marginalized groups, always tend to fare worse than any other group in everything, whether we're talking about criminal justice system, we're talking about our education system, we're talking about our healthcare system. And so solutions then means for me and my work and my research is really identifying ways that we can start to acknowledge implicit bias, know what it is, know the kind of tool it serves to actually create division among groups, and also therefore the division also plays out in terms of the assumptions that people will make about the care that they're providing for that patient. So we know that there's plenty of studies that have shown in many different ways, from mental health to maternal health care, et cetera, that there's biases and perceptions that people have that actually leads to differential in care between Black patients and white patients, Latinx patients, and people who are poor. And so that being said, I think that, I've developed a number of trainings now that have specifically helped our research teams who are engaging with patients in the healthcare system. And now that training has now expanded to really start thinking about how teams and people can start to recognize their own implicit biases and how that biases, how they can actually learn the skills to mitigate that and to be able to actually create the type of change. But it also helps people to become more aware of discrimination and recognize our biases sits in this broader picture that Dr. Wetton just spoke about, and Ubel are really highlighting this bigger effort around that space. And last but not least, in terms of access to care, at Duke Care, I came here 10 years ago now. I just hit my anniversary of being here 10 years. And I came here to start the Office of Health Equity within the Cancer Institutes. And one of the things I really did first is to create a strategic plan with our community to identify what do they believe our Office of Health Equity should be. And the first thing the community says is ensuring that there are people who can connect those who are usually marginalized, disenfranchised, and do not have access to care, connect them to the care, and help the teams have people who actually look like them and reflect the community. And so through that, we have a navigation program that we've developed and really did a great job, I think, in being able to ensure that people have access to care by not waiting for people to come in, but we actually go out with the community to the community and identify ways to be able to ensure that people have access. In the meantime, I want to make sure that when people come into the system and engage with the system, that they also engage a system that actually is responsive and not going to be biased toward people. So, right, we increase the numbers of people coming in the door, but we don't do the work we need to do inside to address the discriminatory and the biases that we may have that impacts people's quality care. So anyway, that's the short version, if you will, about some of the key areas of how we've been focusing on that and really moving towards social solution oriented.
So thank you, Nadine. So Rosa, I'm going to build on what Nadine just shared, and there's sort of two parts to the next question, but I think it's a nice segue from what Catherine started with and kind of where we are right now. So when you introduced yourself, Rosa, you talked about your work in the Latino population, and I think many folks may or may not realize that there are approximately 62 million Latinos in the United States, and that number is projected to double by 2060. And so I'm wondering about two things. One, about this notion of what Nadine was just saying about health systems being prepared, and your thoughts about how likely or how prepared is our health system or health systems across the country to care for the Latino community. And then it would be really great in the spirit of solutions to hear about resilience and your thoughts about not the negatives, but the positives and some of the resilience.
Thank you, Dean. So just to dive in directly into your question around the healthcare system being prepared, when I first started doing work with the Latinx community, I intentionally did not do work in the healthcare system, even though I'm a nurse, and that's where traditionally people place me, is in a healthcare system. I intentionally worked outside the healthcare system because of the number of barriers that the Latinx community face for accessing healthcare. And so I knew that if I wanted to do work with this group, I really needed to extend beyond the walls of the healthcare system. With that being said, that was a while ago, and I unfortunately still see some of those trends today. I think there are some places that do provide healthcare in a very thoughtful and culturally aligned way. And there's some exemplars across the country, but unfortunately, it's not everywhere. So, before coming here to Duke, I was born and raised in Miami, and there's this healthcare system there that's called De Leon Medical Center. And it's just so uniquely tailored for the population in Miami. You can play dominoes when you go and drink a cafecito when you go to seek healthcare, right? The healthcare providers are from the same cultural heritage and background. There's transportation that's provided. So I think they do a very good job at providing healthcare for this population. But unfortunately, in most places, healthcare is not delivered in that way. And I think that's particularly true for areas in the country where there's less of a history and leadership from the Latinx community, where there's more recent immigrant receiving community like North Carolina. So we saw this play out, unfortunately, during the pandemic, where, people talked about, Nadine talked about a pattern that is observed, right, of disadvantage and advantage, who's getting resources and who does not. Professor Wetten mentioned that as well. We saw the same pattern play out during the pandemic for the Latinx community here. First, in the spirit of Dean Ramos's depiction of what our healthcare system should look like in a comprehensive way, we failed to protect the Latinx community against COVID. We didn't have any appropriate protections in the workplace, and the workplace was what was putting people at risk. So we saw there was a time that about 75% of those being infected with COVID here in Durham were Hispanic, Latino, Latinx individuals, although they only represent 14% of the population. I can go on and take up too much time to say how we saw the same thing with testing. We saw the same thing with vaccination. We saw the same thing. One of the worst things we saw were actually when the Latinx community started going to receive healthcare at Duke. There was reports of people going missing. They call them los desaparecidos, people that had disappeared in the healthcare system because We didn't have people that could call their families and speak Spanish and tell them where they were at. So families didn't know whether their loved ones, where they were, if they were alive. It was devastating. Now, to take that really sad story and move into what Dean Ramos asked me to talk about, which is more resilience, is I think that our community came together in an incredible way, in novel ways that we haven't done in the past, that really have helped improve our healthcare system. So now when we go to vaccine events, we have leaders in our community that have partnered with Duke Health to provide these vaccination rates. We now have parity in terms of vaccine access in the Latinx community. And the reason why we got there is because there was a platform where there was bidirectional listening and learning from one another. You know, a lot of what Nadine described about, you know, listening to the communities and the solutions that are there that we don't often listen to, and especially we often don't invest in. And so I'm despite the flaws that we have in our healthcare system, I do have a lot of optimism in our ability to be responsive in the future. But in order to do that, we need to put in a lot more investment and sustainability around a lot of the things that emerged and we learned during the pandemic.
Thank you, Rosa. Those are very powerful sort of words that you're offering and sort of building on what Nadine shared as well. So thanks to both. I'm going to actually pivot a little bit, and I'd like to pull in Catherine and Peter. And so, Catherine, you are one of our sort of resident, if I may, sort of national or global treasures in terms of global work and thinking about disparities in terms of similarities and differences. What can we learn from other parts of the world? What's the same? What's different? What should we adopt? I'd love to hear, we all would love to hear your thoughts on that.
Yeah, so I'll give a couple of examples. One is when we were doing HIV research here in, I'll call the Deep South, one of the things that we found was kind of one of the biggest determinants of the way people had engaged in life, behaviors, beliefs, attitudes, was determined by childhood trauma, particularly before, right around puberty. And it could be sexual abuse, but also other kinds of severe abuse or chronic chaos. And we actually took that after conducting the largest study in the Deep South. We took that same study to Tanzania, and people said there's no way that is going to be the greatest predictor of, as we found here, high-risk behaviors, then not getting tested, then if you're tested, not getting into care, then if you get into care, not staying in care, and if you do everything perfectly, you still have a faster decline in your health. And we actually found that it was the same. That the HIV epidemic in Tanzania, with an even larger cohort there, 1,500 people, the biggest determinant was actually childhood trauma, much to kind of the amazement of our ID docs who were there saying, no, it's going to be transportation, it's how long you wait in care, it's distrust. And distrust follows all of that, right? So that's a one directional. Another example is working with sexual and gender minorities here in the US. We also decided to do a study of sexual and gender minorities in low and middle income countries. Again, people said, well, this is kind of a US phenomena or wealthy nation phenomena. People are, coming out, and so we did a study in Cambodia, Vietnam, Kenya, El Salvador, Brazil, and India, and found, oh my gosh, the levels of what we'll say PTSD symptomatology higher than that of war veterans, Vietnam veterans, Iraqi veterans, Afghanistan, suicidal ideation, all of that. And so what we're really trying to do is say, what can we do? We have some models that we put in place with lay providers providing care for, one case, kids who've been orphaned, but being able to train lay providers in a way that's not possible in the US because you need to have a counseling degree of some kind. And our hope is actually with both of these that we would be able to bring that back to Durham. So if we can provide excellent mental health care for kids who've been orphaned, or for sexual and gender minorities who are struggling with lay providers, why can't we do that in Durham? And we can do that in a way that actually upholds the counseling practice. So we need to have social worker and psychologists, social workers and psychologists who are supervising. But we can train up teachers, we can train sexual and gender minorities, we can train people in different communities to be providing this care. So those are just some of the examples of, there's so much to learn, the local, global, being able to get out of this, the culture that we're in. I would say even in addition, the kind of racial awakening that we're having here, I think is really important in when we work in different countries around the world, where there are, every place is different, but there are differences, there are people who are marginalized, being able to say this, kind of taking the transparency that we're insisting on here in the US right now, taking that to other countries and helping them explore their own histories, I think is really, really important also.
Thank you. So Catherine, I really love sort of your ideas about what we can learn from other contexts. And I love sort of the broad consideration of workforce, which I think, Peter, it made me think about
Yeah.
too, because you have thought a lot about this. Earlier this year, you actually wrote a paper that was really about the lack of diversity in our healthcare workforce. And so I'm wondering if you could share some thoughts from your perspective about what that means, and if there are solutions or suggestions that you have about how we can better align our workforce with the kinds of things that I hear Catherine saying, Nadine and Rosa. What do we do?
Yeah, I think the first workforce is really important for people's health, especially the healthcare part of their health. If you go to a provider that doesn't understand you, doesn't know how to communicate with you, has a harder time, you don't trust them as much, or they don't engender trust from you, you're going to have poorer outcomes. And so we need diverse workforce. And I particularly have looked in medical, in the physician side of this, just because that's my background. Actually, I'm curious, Dean, what is it? Do you know how much it typically costs to go to nursing school?
It's fairly expensive, especially relative to the salaries and some of the low wages that nurses earn.
And do you know what the average number of schools people apply to when they apply to nursing school? Any sense of that?
What I can share is that last year we had across the country 80,000 qualified applicants that were seeking education in schools of nursing, and that were turned away because we didn't have capacity. In our own state, North Carolina, by 2026, we have an estimated shortage of 13,000 nurses. And so I think we've got some work to do with our workforce.
Yeah, and so just making it affordable and getting qualified people into where we need to train more people in the nursing part of the workforce, and nurse practitioner, et cetera, really important. For medical school, we have a certain number of slots, and maybe whether we should have more or less is a good question. But we want a diverse physician workforce, and that means getting into medical school, which is hard. It's always been hard, although somehow I got in. But I think the typical student at Duke is applying to 20 medical schools. And so there are medical schools that are having free tuition, the thought being, wow, that should make it affordable for everybody. Well, you have to get into that school to get that free tuition. And by the way, if they have free tuition, you can bet there's a lot of people applying, so it's going to be hard to get in. I also think free tuition is more about the US News ranking than it is about benevolence of medical schools. That's an aside. But here, I do think that this is a fixable problem. I think that we are not thinking about the financial cost of applying to 20 medical schools. We're not thinking about what that means for every application costs money, every secondary application costs money. The MCAT test takes money to take the test, but many students pay money to prepare for that, which often, of course, gives an advantage to people who can afford that. We've added new testing requirements to get into medical school. Those tests cost money, and the prep courses cost way more than that. Then before the pandemic, people went to their interviews if they got invited to interviews, which meant not only getting fancy clothing, but all the transportation costs, housing costs when you get there, et cetera. So I think we can do a lot to try to make it easier for people to afford to apply to medical school. We might even need to set a limit on how many schools people apply to potentially, but at a minimum, we can reduce travel costs. That's happened in the pandemic. People Zoom, wow, they could Zoom for interviews. Why didn't we think of that before? We can reduce fees or waive fees for applying to schools. And we then, of course, once people get in, we should try to make it affordable.
Thank you. So I see that there are some questions that are being posted to the chat. So in a second, I'll start to invite some additional questions from our audience. But I guess I'd love to maybe stick on this point for a second, Peter and Catherine, Rosa, and Nadine. So what I was struck by, Catherine, by what you were saying that sort of was related very much to Peter's comments, is that there was this notion of a healthcare workforce that was very broad. And so clearly includes physicians, includes nurses, as you know, Rosa and I, but it also includes social workers and psychologists and community health workers and other kinds of key actors that can help us collectively to achieve sort of population health goals. I wonder if the panel has any thoughts about how we can optimize our workforce so that we can achieve reductions in disparities and improve health equity.
So I'll just hop in to say quickly, I do think that kind of in the vein of what Dr. Barrett was saying earlier, reaching into the community and empowering and educating as much as they can. I think there's a tremendous resource there as we're looking at kind of mental health needs. And mental health is not the word that you would use, but I'm going to use that for today's looking at mental health needs, but also navigating, understanding systems, building trust. Our country, I mean, we've just done such a terrible job in so many ways with identifying, creating communities that are marginalized, and so to be able to empower community members with pay to be navigators, to work within the communities, identifying informal leaders would just be tremendous. So we need to diversify nursing for all of the different professional levels that are there, but then also really including and identifying community expertise that's already there, and building that up, training, building up. I think would go a long way.
Nadine, Rosa?
Yes, I'd love to add to that. I could not agree more. I think, when we talk about this need for a more diverse workforce, right? We're talking about providers. We're also talking about, let's admit, at Duke, we do a lot of research. We need to think about diversifying those who are doing research. And the other part that we don't really talk much about in terms of the importance of diversity, which I'm very much an advocate of, I know my colleague Rosa and I've been on this mission for quite some time together, is really focusing on increasing diversity in research participants. Because when we think about the research that we do, oftentimes most of the evidence, most of what we practice in medicine actually comes from studies and research. And if we don't have the type of diversity we need in terms of participants, we will not know how effective those types of treatments are, that type of program is. Even if we're talking about testing a research study that's looking at community health workers and the impact community health workers have in the community, if we don't have diversity in those community health workers, we're still not really getting and hitting the mark. So I really want to highlight that when we're talking about diversity, we know that diversity matters, not to sound cliche, but it really does. It matters because it allows us to really understand the breadth and depth of effectiveness of anything that we're trying to do to improve health. anything. And the key part of that means that we have to engage our communities as experts. We have to create the pipelines, which is a lot of the work we're doing now within the Duke Clinical Translation Science Institute and a new center that I now direct called the Center for Equity in Research, is really engaging our communities and creating pipelines in the community. We just started a whole pipeline with Durham Tech to start actually helping, because 70% of the students that are actually a part of Durham Tech, an associate's degree, are underrepresented marginalized populations, 70%. And so now we just started an Equity Scholars Program to create a pipeline of bringing people right on through to Duke, that they can actually be in these spaces where when a patient comes to the door, they see people who look like them. They see people who speak their language. They see people they see a society and a community and a work environment that actually is showing some evidence, not full, but some evidence of embracing the culture and understanding the importance of people's culture, and that the care that we provide should be responsive to that. So I think that when we talk about diversity and the importance of it, it cuts across both our workforce. It means being intentional and engaging and identifying our partners, our other partners, NCCU. We have a strategic partnership with North Carolina Central University, which is our local HBCU here, like literally 5 miles away, creating pipeline and partnerships where we really are working together to improve health with our community. And anything less than that, I think we will miss the mark. And COVID-19 has shown us, without question, I've sat in meetings, Rosa and I have sat in meetings where we saw a plan of action that we had us do to address COVID-19. The community comes back and says, what made you think that would work? And then they come up with their own plan of what they thought would work. And when we implemented it, guess what? It worked. And so again, really just being able to really highlight that our expertise and what we call expertise, because we're at Duke, sometimes I think that we oftentimes don't think that the diversity of our community and our patients' voices and perspectives are critical to that as well.
Yes. So Rosa, I'm going to ask you the first question. We have roughly 10 minutes or so before we have to wrap up. And so there's a question from Jim Newman, and he's asking about impediments to health equity and issues of misinformation and changing attitudes among target populations. And so COVID kickstarted access to telehealth here in the US. Shouldn't a toolkit of solutions include a robust use of social media in some way to provide information, not just about what is a vaccine, but how to get solutions in your community or state?
So I think that this issue of misinformation and social media is really important in the context. And I would also emphasize the importance of using different channels of communication to reach a wide audience. And I'll just give you an example. 2 days ago, I stopped in a Mexican store to buy some tamales, right? In that store, I'm walking in, I see this lady with her 3 kids. And the store seller knows her, is asking, are you going to get your kids vaccinated? Oh, yes, I'm going to get my kids vaccinated. Oh, I'm not going to get my kids. I got vaccinated. I'm not going to get my kids. And there was this natural exchange that happened that resonates a lot with our conversation about natural leaders in our community that are real big influencers. And so I think that our strategy needs to include making sure that those communication channels are being leveraged, as well as these other social media channels that we typically think about.
Thank you. So panel, I'm going to actually ask this to anyone who feels like they'd like to respond. So Sarah asked a question about measurement in research. And so Sarah's wondering, what are the main points of measurement when identifying health disparity? How should we think about disparities from a measurement point of view?
I'll jump in on that. So for the perspective that I take, which is kind of this stepping back, what's happening in societies and communities and things like, there shouldn't be very few of our disparities. I think you actually started with this, almost very few of our health disparities are driven by genetics or differences, biological. But when you see a group of people that can be identified by skin color, by ethnicity, by section and minority status, by some characteristic that is innate to them and doesn't have, then there's something going on in society. That's where we see, the disparities. So we say, okay, what we can take our highest achieving, so who has best maternal mortality outcomes, who has best information, whatever it is. And then if you're seeing there's a group of people who you can identify by some characteristic that is not about our biology, then it's about social determinants that are happening in the community. So that's what we're looking at, is like when we're looking at inequities, that's what I'm looking at. How do you reduce those inequities? I'm hoping that our as teams we will continue to improve health, and why is it that we're not improving at the same rate?
That's a terrific answer, Catherine. From my point of view, I totally agree with what you said. I think too often we focus on things like ethnicity or race, and we tend to segment on that. And then the narrative becomes reinforced that X community has this disparity. And while that may be important, I think it misses what's really driving that and what those causal mechanisms are. And then also, I think, Rosa, what you were saying about not just the social processes that are shaping those outcomes, but also, are there places that are amenable to change? Are there solutions? Are there factors that can help us to mitigate or reduce the effects of whatever that process is? To me, those are things that we also should be measuring. So Peter, question for you. It has to do with workforce. And so Chris Adams is asking, we've all discussed the importance of diversifying our healthcare providers, clinicians. Chris's question is, shouldn't we focus on expanding health coaching and patient health advocates as a more accessible way to address access, equity, and outcomes?
I'm a huge fan of having decision coaches. A lot of work I've done has shown how hard it is for patients to have their voices heard by their clinicians, and that's even empowered white patients come in and have a hard time. That's even like physicians as patients have a hard time sometimes. So I think having non-clinician coaches is a very, very important thing to do. Great suggestion.
Thank you. So another question, I'm going to try to get through as many of these as possible. So a question from Charles Anderson. So Charles is asking, he says, I'd like to hear more about barriers to entry into the profession and how can we overcome resistance to eliminating or reducing those barriers. It seems like political factions are driving resistance to discussion. How can we help?
When you ask a question about improving politics, you should expect a long pause before anyone jumps in to answer. Because just thinking, like, even just what Rosa was talking about earlier about like trying to really hinting at the idea that you need good messengers, right? As much as anything. If you look at one of the least vaccinated groups in this country right now is actually white people, right? Rural white people. We need messengers to get out. So I think that's certainly something we would want to focus on.
So there's a specific question for Dr. Gonzalez-Guarda, Rosa. You mentioned the Miami model, where it's a model that is tailored to the Latinx community. I think that conceptually sounds really cool. Do you see this as a stepping stone until we address the lack of diversity, addressing biases, et cetera? Or do you see this as a better way to provide care to different populations?
I do see it as a model that could be leveraged, and it's understanding how that model works from who's designing the system. Okay, the Leon system is designed by Latinx providers, and that are designing it for Latinx populations. And so we, mistakenly in healthcare often, this whole concept of bias, it's, sometimes it's intentional, but most of the time it's not. It's, a group of people that are like-minded, designing it for what they would like to see in their families and what they know. And so we know that having leadership from the onset that involves, to the point of a lot of what we're saying, leadership from the community voices themselves in that design is really important. At the end of the day, when you look at the way that they deliver care, it's very people-centered. Very much, they do a lot of training on fostering respect and like that personal interaction that's so important. And so I think that those, those are all things that could be adapted for diverse populations.
Mhm.
So Nadine, I was going to ask you the next question. Is that okay?
Yeah, absolutely.
Nadine, as we kind of wind down, I guess it would be remiss if we didn't recognize COVID-19. And so I think COVID has certainly been at the forefront of a lot of our public health efforts globally. And so do you see some opportunities in terms of reducing social determinants of health or eliminating, probably better put, health inequities that COVID has presented us? How can we use COVID as a spotlight for helping to advance the work both within COVID and across many areas?
Yeah, that's one of the things I have been writing about. I'm actually writing a grant specifically focusing on that right now, and also developing a strategy in that space. I'm glad that you asked. You know, a number of things that I noticed about COVID that we cannot ignore, right, is that when we were talking about health disparities and the inequities and that people were dying for no reason, things that were totally unavoidable, we've known this forever. And it was not called COVID, it was called diabetes, it was called hypertension, it was called any HIV, et cetera, right? So we knew this, it was not new to us. What was really amazing to me is how quickly funds were made available just to be able to pivot so quickly to address COVID-19. And then even more so as people started to ask for the numbers, specifically as it related to the race and ethnicity, right? And the Latinx population, the Black population. Then more funds started to show up even more. And so to me, it really speaks to this idea that when the challenge is brought to the light, all of a sudden the floodgates start to slightly open up where funding was not available for anything now it's available here. And I'm speaking specifically about programs like community health worker programs. I really credit, of course I credit the researchers and all that's been doing great work in terms of vaccine and testing, et cetera. But what the community has done nationally to ensure that we reach the most underserved, underengaged, hardly reached populations has been absolutely amazing. And so I would say that one of the things that we can learn is that money can be found when there's a political, right, that's when, commitment to it. They'll find the money to make it happen because it can happen. The thing I'm concerned about, and so I'm hoping we can become more advocates for, is that as we start to move and COVID starts to progress and becomes more silent, just as George Floyd's murder has become more and more silent, right? I think that what we need to start really doing is become people who advocate for us to continue this work to address health disparities, period. And not just around COVID-19, but starting to focus in and start really being honest about what this is. I think the other thing is we talked a lot about diversity and inclusion, which again, I was a great advocate for that to some extent, but I always felt like if we talk about diversity and inclusion and don't put it within the context of structural and systemic racism and solutions toward that and engagement, we miss the mark because then it feels like we're just identifying people to put in spots that look different and not recognizing that there's these culture and policies and practices in our systems and in our community that reinforces it. And then the last thing I'll just say is really about two things. One is trust and trustworthiness and understanding the difference between the two, and how do we as institutions become more trustworthy? And that again is something that actually Rosa and I are working very much so on this whole effort now to understand and work with our community to know what does it look like to really be an organization that when you walk in the door, that there's an element of trust there. What does that institution look like? What does the care look like? What does the conversation look like between a provider and a family and that patient? Those are the kinds of things that we really need to start moving forward in. And we learned from COVID that it kind of forced us to have these conversations that we weren't having before. And so I think those are three key things that I would say. And again, the community engagement work, the answers are there. So the more we can support funding in that space, the better it will be.
Thank you. I wanted to just say to each of the panel members, that was a terrific discussion. And to all the folks, your comments and questions. And I see Charles is also thanking you all. So we're getting positive feedback. It was really terrific. Thank you.
Thank you all for joining us this evening. That was a truly fascinating conversation about, I think, a lot of things that will leave a lot of us thinking tonight, and hopefully for the rest of the week at least. Thank you all for joining us this evening on the call. I do have We have one more session in this topic of wicked problems that's called Building Thriving Communities. And we'll be looking at things like evictions and homelessness, refugee resettlement, and food security in our communities. So if you would like to join us for that session, that will be on December 15th. We also have many other amazing programs that are coming up this fall. Please be on the lookout for the next Forever Learning newsletter that'll come out next week that will give you more opportunities to engage no matter where you live in the global community. I hope you have an enjoyable evening, and I will see you on the next Forever Learning session. Thanks so much. Bye.